Okay, you guys, what's up? Dr. Tochi here. I'm a little bit nervous today. I'm here for another day in the life or night in the life. I'm here doing a night shift as an internal medicine attending. And today I'm nervous because I had a shift a few weeks ago on April 11th, and today is May 9th. On that last shift, if you guys didn't see that vlog, you can go check it out in the top right-hand corner. I had quite the chill shift, and I was a little bit nervous because I was going throughout that entire night shift. I was like, when am I gonna get an admission? Is something going on in the ED? When is the other shoe gonna drop? And I went through the entire shift without admitting one single patient, and I barely even left this room. So today I was a little nervous coming in because whenever I have a shift like that, usually I get it back in blood on the next shift, which is supposed to be today. And so far it's okay. I didn't start this vlog right when I got in. Right now it's 11:30, and usually I start these shifts at 9 p.m. And so far it's been okay. I'm getting a steady diet of admissions. So far, I'm gonna be dropping an admission for one of the patients right now that actually came in for septic shock secondary to a urinary tract infection. And for those of you guys that aren't aware, usually whenever we have a patient that comes in for sepsis, basically an infection, we have a whole protocol cyst. And what I like to use is actually think of it as a VAPES mnemonic, VAPES, and that's pretty much the whole management system. And what we do is when we have someone that comes in for sepsis, we think about volume because you actually have to resuscitate someone with fluids to kind of help clear out the infection and the inflammation that comes along with it. So usually we do 30 cc's or 30 milliliters per kilogram of weight, and that is something they just get bolused right away. So instead of like a slow, steady infusion of fluids, we just push all the fluids right in the beginning to open up their intravascular system or their blood system. So that's usually the first thing that we do and that we think about for the VAPES mnemonic. The second thing that we think about is antibiotics. So we think, what is the actual source of the infection that we think it's coming from? Is it something coming in the lungs, something in the skin, something in the urinary system? Is it a neurologic infection? Is it a GI infection? And based off of where we think the source of that infection is how we tailor the antibiotics to actually manage that person. So this person's coming in for a UTI, aka pyelonephritis specifically, which is a complicated urinary tract infection. And usually for urinary tract infections, I manage it with cephalosporins. Specifically for this one, I'm going to use ceftriaxone. And then we also get to blood cultures and urine cultures to see, is this an infection that has gone into the blood? And we also try to get a urine culture to see what type of specific bacteria this actual person is having. If we didn't have like a urinary tract infection, it was just some other source, I wouldn't get the urine culture. But for this person, because we see that the urinalysis, which is the first pass to actually check out someone's urine, was positive for a UTI, I usually get a urine culture after the fact. So even though I throw antibiotics at someone that comes in for sepsis for a specific type of source, I wait for those urine or blood cultures to come back to see, do I need to escalate these antibiotics or can I narrow it down based off of the sensitivities to the actual bacteria that's causing the infection. So that's the A as part of the VAPES mnemonic. For the P, that is the pressors section. Now, pressors or vasopressors are medications that we use to clamp people's blood vessels down to try to raise their blood pressure up, because with sepsis, you can have a lowering of someone's blood pressure. So usually what we do is that we don't really start pressors in someone unless they don't really fly with getting the volume from the V and the VAPES mnemonic that I talked about earlier, because if the fluid is not opening up the blood system, then we actually need to use pressors to kind of push down the blood vessels to get blood pumping throughout the entire body. So usually what I would start is something known as levofed, also known as norepinephrine. And a second agent that I would actually throw on after that is vasopressin, which is another medication as well. Usually I wouldn't use dobutamine for septic shock, but usually for shock, we think about septic shock, obstructive shock, we think about cardiogenic shock. and then some other things, as neurogenic shock as well. So we have to think about how we actually choose pressors, because based off of the type of shock that you have, which is when you start someone on pressors, you can kind of determine what type of pressor that you can actually start. And then the other part of that mnemonic, the E, is end organ damage. So whenever you have sepsis, you can have other organs in the body that start having damage as opposed to that. And what we actually see is if someone has having an AKI, so is their creatinine, which is a measure of their renal function, is that going up? Are they having a lactic acidosis? So a lot of times when you have an infection, you can have lactate, which is a byproduct of these infections, that starts going up, which is a marker for really, really poor perfusion in the actual system. So lactate is another thing that we see. Some other things that we can see as well that can go up are troponin. So that is signs that the heart is being affected by the actual infection. So these are all things that we would order in the initial order set to see, are those elevated, meaning that we're having some sort of end organ damage in the system. So that is the E. And then the last part of the actual mnemonic is S, which is steroid. So if we have someone that is in septic shock, that has already gotten the fluids, the 30 cc's per kg, they're already started on pressors, and they're still having refractory shock, so this is a very, very severe infection, then you can think about starting a steroid to try to artificially increase the blood pressure as well, to kind of help with the actual shock. Now, it's kind of like a tricky situation that is like a last resort, because usually with steroids, it does suppress your immune system. So we usually don't like using steroids whenever someone has an infection as the source of shock. But if the shock is so overwhelming, then we kind of have to start steroids. So usually we would do like hydrocortisone, like 15 milligrams, I believe. It's part of our order set. So that is usually what we think about when we're treating our patients with septic shock, or just shock in general, or sepsis in general. So that is what we got going on right now. Before I keep on jumping into the rest of this conversation, I'm going to drop these admit orders. We have like a whole order set, and one of my seniors when I was in residency actually created this order set, because some of these things in these order sets are like, you got to change every specific thing. So I have like a pre-filled order set, and then I just kind of adjust it based off of how my actual patient is doing. So this person came in with septic shock, but they're no longer on the pressors anymore. If you have pressors or any medication that needs to be managed or checked every 1 hour or pretty continuously, then you have to send them to the ICU, because on the floor, usually you're only checking things every 4 hours. So we can't have someone in the floor or in the tele floors, which is cardiac monitoring, that is on these continuous medications. So this person's gonna be going to the acute floor, which is med surge. They're gonna be going back home. They live in a city that's not too far from this hospital. And some of the parts of this order set, we think about adding diet orders, the code status, this person's gonna be full code. What are some other things that we're gonna be doing? So just add in some vital checks for this person. I don't need to be doing neuro checks. We are at a stroke hospital here. So this is it's a stroke certified location. So we get a lot of strokes as admissions here. So we'll see if we get a actual stroke admission today. But I'm gonna throw in all these things and make sure this person gets a bed. This person was also nauseous. One of the things that I actually noted when I started admitting more and more people with pyelonephritis, especially in women, is that they tend to have headaches, or if they have migraine histories, that actually gets worse as well. So I actually asked this patient, and she actually is having an associated headache as well. So I'm gonna be putting in some pain medications for her. That way she has some medications to help with those headaches. Because usually this person has a urinary tract infections, I also check to see if their kidneys are being affected. So one of the things that I mentioned in the end organ damage that I mentioned earlier is the creatinine. So if the creatinine is elevated, then usually what I would say is that I wouldn't want to use any pain medications such as NSAIDs like ibuprofen, because that can make the renal function worse. This person's renal function is actually fine with their creatinine being normal at 0.7. So I could add in some ibuprofen, but I'm just going to stick with Tylenol for her because she is having fevers. So I'm going to throw that in for pain medications. She's also feeling very nauseous, and she was vomiting when she first came in. So I'm going to have some PRN nausea medications. The thing that you have to think about as well for nausea medications is that a lot of these nausea medications can increase your risk for QTC prolongation, which is one of the parts of your heart rhythm. So a lot of these medications, if you increase the QTC for too long, then it can lead to something known as torsades, which if your QTC is over 500, then you're at a huge risk for that. And I can see that someone is chatting me through the chart, so I'm going to respond to that soon. But basically, you want to avoid QTC prolonging medications as much as you can. So usually a elevation of a QTC over 470 for women is abnormal, and over 450 for men is abnormal. So looking at this person's EKG right now, it looks like their EKG is currently 412. So I wouldn't be concerned about starting any QTC prolonging medications for her. So I'm going to throw in some nausea medications for her, going to throw in some PRN or as needed constipation medications. And I think that's everything that she's going to need. So yeah, she's going to be going to the floor. I can probably DC these Levofed orders, yeah, because she's no longer in shock. So I'm going to stop that. One of the things I like to do as well is that put that in for her. One of the things that I like doing as well is that although these patients come in without constipation, I always like to have some as needed constipation medications in there, because people that come in constipated, especially at older populations, if they go for more than like 4, 5, 6 days out of the week with no bowel movement, I get concerned with them retaining, which can lead to a perforation down the fact. So that is our first admission. We already have one more admission than the entire shift last in April. So we'll see how the rest of the today goes. So let me throw in some other orders. I see we have another person on the list right now to see if we need to admit. It looks like another patient with sepsis, but this person needs to have a CT chest, abdomen, and pelvis to see if they can find where the source of the infection is, because for this hospital here, I don't believe we have urology. So if there is like an obstruction, we need to transfer them to another hospital so they can get the appropriate specialty services to see them. So hopefully they don't have an obstruction and then they'll just come here. But if not, then we can kind of work on getting them transferred to another hospital. But that is pretty much how the initial part of this shift is going. I know that was a lot of me rambling, but I'm just kind of word of mouth, just kind of like word vomiting my kind of process and what I do whenever I admit people. So let's go ahead and just drop these other admission set, look at the ED board, and then we'll go from there and see if we have any other work to do for the night. One of the things that I really hated managing when I was in medical school was patients that had DKA, also known as diabetic ketoacidosis. And the reason why I did not like managing those patients is mainly because I did not have like a really good system for them. So let's go ahead and do a little bit of walking because I've been sitting down for a little bit too long. But I wanted to tell you guys kind of like my framework in terms of how I manage people with diabetic ketoacidosis now that I've been doing this for a few years. Now, the 4 things that you want to think about when you're managing people with diabetic ketoacidosis is 1, your glucose levels, 2, your sodium levels, 3, your potassium levels, and then also 4, your acid base levels. So let me just go ahead and turn these lights on because it's a little too dark in here for my liking. So the first thing that you want to think about is your glucose levels. That's one of the biggest things that you're managing because in DKA, you have wildly uncontrolled glucose levels. So usually what we do is that when your glucose levels are out of whack, we have them on a insulin drip, and insulin is something that lowers your glucose levels really, really low. So So when we have someone with the glucose levels that we're trying to manage, you want to think about it. One, are your glucose levels too low while they're on the insulin drip, or are they too high? So if they're too low, and usually the cutoff mark that we have is 200 to 250, if it's too low, you're going to be adding fluids to them in a continuous fluid drip with something known as dextrose or D5. So that's one of the things that you can do. If they're too low, you can add D5 into the fluids that you're giving them to try to keep their glucose levels above 200, because you don't want to lower your glucose levels too low, because that can come with a whole host of other issues. So that's one of the main things that we do with the management of DKA. The second component you want to think about is your sodium levels. Usually in your sodium levels, you want to think about, is your sodium too low? So is it less than 129? Is it normal, or is it too high? So hypernatremia. Usually what we'd say is that if you have someone with hyponatremia or normonatremia, so normal sodium levels, then you can have them be on a normal saline drip. So if they have hypernatremia or really high sodium levels, then you can put them on a half normal saline drip. And the reason why we make that differentiation is because the normal saline that's in that fluid, it has sodium in there. So you don't want to be adding too much extra sodium to someone that already has hypernatremia. So that's why we have them on a normal saline drip at the regular rate, as opposed to the half normal saline drip when you have like really high sodium levels. So that's what we usually do for managing the sodium component of DKA. The second component, we talked about the glucose levels, we talked about the sodium levels. So the next thing you want to think about is managing your potassium levels. And the reason why we think about potassium when managing DKA is because when you have someone on an insulin drip, the insulin not only lowers your glucose levels, but it also lowers your potassium levels. And whether your potassium levels are really, really low or really, really high, both of those ends of the spectrums are very, very dangerous, which can lead to death. So one of the things that we think about are two separate numbers, 3.3 and then 5.2 to 5.4, around that range. Before you even start someone on an insulin drip, when you're managing them for DKA, you have to check the potassium levels. If they're less than 3.3, you should not start the insulin drip until you fix that potassium level right there. Because if you add an insulin drip to someone that already has a potassium level less than 3.3, you're going to cause them to die, because that's going to lead to an arrhythmia. So after you have checked their potassium, and if it's above that range, what you want to think about is whether or not you need to add potassium into those fluids that you had earlier, whether it's the normal saline, the half normal saline, or the dextrose or D5 in the fluids. If your potassium is above 5.2 to 5.4, you do not have to add in extra potassium into those fluids, but it's less than that, then you do have to add potassium into those fluids, so you don't lower the potassium further to a point which can lead to a lot of arrhythmias. So that is the other thing you want to think about when managing someone with DKA. So we've talked about the potassium, we've talked about the glucose, and then we've also talked about the sodium. The most important part now is thinking about the acid-base levels. While you have someone on a DKA protocol, you're going to be taking a VBG, which is a venous blood gas, and then you're also going to be checking with the BMPs, or basic metabolic panels, for looking at the bicarb or CO2 on some of them. And the reason why we check that is because with DKA, you can have a buildup of a lot of products, which can lead to ketones, which can lead to your acid levels increasing. And what we do is that we use the CO2 as a marker of actual acid base. And usually if it's undetectable or less than 8 or just something really, really low, you have to be getting VBGs to actually track to see what your acid base levels are at. Because if you're really, really acidic in your body or really, really basic in your body, that can really lead to damage of your actual cells in your body and can cause you to decompensate and get worse and worse and die. So that's one of the things that we're checking as well. And we're also checking on the basal metabolic panel, or the basic metabolic panel. We're going to be looking at the anion gap. And the anion gap is a marker of tracking to see what byproducts are in the system that's leading to more and more acidic levels in the body. So usually if your anion gap is really, really high, so above 12, 10 to 12, that means that you have a raised anion gap. And that is something that we're checking for to see whether or not a gap has closed, meaning that has gone below that 10 to 12, meaning that you're no longer in that danger zone. However, in more up-to-date management styles of DKA, we're not just looking at an anion gap closing, we're also looking at the bicarb or acid base levels as well. So if your acid base levels are really, really low still, even though your anion gap can be closed, you still have to keep them on the insulin drip until that bicarb or bicarb goes back up to normal levels. So this is how I kind of think about managing people with DKA. I think about the sodium levels, the glucose levels, the potassium levels, as well as the acid base levels with the anion gap, the bicarb, as well as the VBGs to see if you're acidic or not. So that's just something that I've kind of done more and more often or not. If you guys are medical students or residents right now, really get down how to manage people with DKA. You do or have them on an insulin drip, and when the insulin drip and all those things are resolved, usually you can transition them back to the sub-Q injections of the insulin later on down the line. So pretty long process, a lot of different things to consider, but very, very dangerous syndrome. So you really got to have a good system on how to manage it. This is a young woman who has no significant past medical history except for appendicitis in 2025, status post appendectomy. The patient noted that she has had a history of UTIs in the past, and at that time of having these symptoms, she took some Tylenol and some other medications that did not help her symptoms. She also endorses nausea and vomiting and still feels nausea at this time. However, is no longer vomiting, period. She's still able to tolerate PO at this time, period. I'm a huge proponent for using dictation whenever I'm doing these admitted shifts because, I don't know, it just feels more natural for me to do that as opposed to just sitting there and typing. I just love dictating, and I think that I couldn't really do this without it. So that's one of the things that I've noted at my program back at my other institution. They actually have this thing known as AI Scribe, which I don't really use too much for palliative care in my normal field. However, it is really good for other fields. And I was doing a rotation with some pain specialists, and they were saying that it's been like a godsend for them, especially because they see so many patients in such a quick amount of time. They can't really be spending too much time just typing there the whole time, as opposed to just letting the AI do its thing, capture all the information and put it there for you. Of course, you have to do your own editing after the fact, but it's just a huge time saver and a huge proponent for medical care providers, because one of the main issues that people have for burnout in the medical field is no documentation and all of that administrative stuff. So that's one of the things that I've been really happy to see in the advent of this medical society and medical career paths that people can have. But I don't know, what do you guys think? Do you guys work in the medical field? Do you use AI in your medical practice? And even if you're not in the medical field, do you guys use AI for any sort of documentation? Let me know in the comment section down below. All right, so it is officially 3 a.m. We have 4 hours left on the shift. I wanted to come out here and talk to you guys about my experience on the pediatric unit for my fellowship, but I just got a page right now to see what the next admission is going to be. So I think this is coming from the ED. So I'm gonna go back to the workroom right now and then call them back and then see if we have another admission coming our way, or if we have maybe one of the nurses on the actual floor or the ICU that's reaching out. So let's go ahead and call these people back. The shift is going well so far. I have one admission, the one I told you guys earlier about for the sepsis patient. So let's go ahead and see what we have next. I saw one person came in new from the emergency department. It looks like this person was in their maybe like 80s or 90s. And I saw dyspnea, so that may be a potential admission. So let me just go ahead and check out the list. We have 1, 2, 3, 4, 5, 6 people in the emergency room right now. One's getting discharged, one is marked for admission, the other one is marked for transfer, and then the other one's marked for discharge, and then the last one is being evaluated by the ED doctor. So I think they might be reaching out to me for one that they told me a little bit about earlier, which was a sepsis patient. So that patient, I believe, had signs of like a urinary tract infection that turned into sepsis, kind of like the earlier patient that we talked about. But for this one, I think they wanted to get a CT chest, abdomen, and pelvis for an evaluation of a source. And the reason why they did that is because usually if you have a urology patient, if there's some sort of like obstruction, then they need to be sent out to a higher level of care just because we don't have urology here. So we want to make sure that they're at the most appropriate hospital when they're getting evaluated. So let me go ahead and check out this CT chest. It looks like on this CT, cardiomegaly, meaning they have a bigger heart than normal, CAD, coronary artery disease, okay, pulmonary artery enlargement, okay. So far I'm not seeing anything super concerning. It looks like they have a AAA, which is good to have that for the clinic doctor because they need to actually follow that just to make sure that they have them on the appropriate medications so it doesn't rupture in the future. Let's see, the lungs cannot exclude acute infectious or inflammatory process. All right, so nothing huge on the chest. Maybe some sort of thing is going on in the lungs right now. But let's go to the abdomen pelvis section right now. Looks like they got some gallstones, mild central mesenteric stranding. That's pretty non-specific. Non-formed stool. Okay. I'm not really seeing too much on this imaging, so they might actually stay here for an admission. So they're probably just coming in for a UTI. Looks like they have an AKI, meaning that their renal function's a little bit out of whack. They've got some hyperkalemia. Sodium is barely low. Okay, so nothing too crazy. So let's go ahead and call them back and see what we got for this admission here. All right, thank you.
Yeah, for sure. All right, thanks.
All right, bye-bye. All right, so looks like we have another urinary case. Looks like, I talked about this on the last vlog that we had for my night shift, but there's always a theme for our admissions. Last night, or the last shift that we had, there wasn't any theme just because there wasn't any admissions, but the one before that, I believe it was more so a kind of stroke heavy day. The one before that, I believe it was more of like a sepsis day. So looks like today is going to be a sepsis day. So I can't remember exactly what the frequency is. When people have indwelling Foleys, that means that usually they leave with the Foley and it stays in because they have some sort of issue voiding. I'm not really completely sure what the guidelines are for how frequently they need to switch them out for. So let me actually ask Open Evidence right now. How often do you need to have an indwelling Foley exchanged? And the reason why we have to exchange them is because of situations like this. If you leave them in for too long, then you're at risk for getting a urinary tract infection, which can turn into pyelo in other situations. Pyelo is more of a complicated UTI picture. There's uncomplicated and there's complicated. But the reason why we try to exchange them every so often is just so we can avoid situations like this, especially in our older population. So it looks like they're supposed to be switching out indwelling Foleys every 4 weeks for most patients. So I'm actually going to turn that into a Anki flashcard. I still use Anki to this day for those of you guys that are still medical students. I think it's like really perfectly, it's like the perfect study system, honestly. And I think that if you guys are in your early career as well, then you guys should also be doing this as well. And just keep on with the repetitive, not only training, but studying as well, because you're going to need to do recertifications of your license every few years. And if you've been studying consistently, those retests are not going to be as bad. So I believe my retest is in another, I think it's every 10 years and then every so often after that. I can't remember exactly, so don't quote me on that. But let me go ahead and make this into a flashcard, and then I'm going to go downstairs to the emergency department, admit this patient, and we'll go from there. Or sepsis secondary to a catheter-related UTI. Sepsis secondary to a repeat catheter-associated UTI in the setting of needing a repeat Foley exchange. period. Patient was noted to have an associated AKI as well as hyperkalemia, while in the ED was noted to be in septic shock requiring levofed, period. Now being treated with ceftriaxone, period. All right, so we just saw our second admit. Pretty simple admit, older gentleman coming from a nursing home. Only symptom that he was having was weakness, which it's really tricky with these older patients because they don't typically present normally when they have infections. Sometimes the symptoms are quite subtle. So the only thing that he had was weakness. He didn't have like the burning sensation, suprapubic abdominal pain, any back pain. And he also has a Foley in place, so I didn't presume that he would have those symptoms at all. But we have to kind of be careful because with our older patients, they can go for a while without having some of these symptoms noticed. So the only thing that he noticed was that it was harder for him to transfer over into his, his wheelchair. So weakness and confusion are the biggest things that I look out for whenever our patients come in with infections. And it's some of the things that people should be worried about at nursing homes or at living facilities if you have a gentleman or a woman that comes in with any of these symptoms. So I'm gonna throw in some admit orders. We already exchanged the Foley in the emergency department. So that's one of the things that we mentioned before. You have to exchange them every 4 weeks. And if they're other certain types of Foley, sometimes they can go up to 12 weeks, which is a little more friendly for the patients, so they only have to come in only 4 times a year as opposed to every month, which is pretty taxing. But despite all that, gonna get some orders in, put in some antibiotics, and then go from there. And then it's about to be 4 o'clock, and then we'll be at the final stretch of our last 3 hours of the shift. So fingers crossed it goes well. All right, so just finished admitting that patient. That's officially the second admission of the shift. It is about to be 5 o'clock and we'll have about 2 hours left on the shift before I have to leave. I'm gonna take a look at this ED list just to make sure there's no other potentials coming in, because I do wanna talk to you guys about some stuff that happened during the week at my fellowship program. There is currently 4 people in the ED. One of them's getting discharged, another one's getting discharged, another one's transferring, and the other one I just admitted. So I think we're in a good spot right now. So let's go ahead and step outside the room. I wanted to talk to you guys specifically about how my week went with the pediatric program. For those of you guys that are new, I am a fellow in a hospice and palliative care program. And one of the things that I have to do with the palliative care program is that I have to do 2 weeks of pediatrics. And it was a little bit weird for me because I haven't managed a pediatric case in, when was the last time? Probably in like 2020. So it's going on 6 years now. But despite all that, whether you're pediatric or non-pediatric trained, you have to have some sort of experience with pediatric patients for the palliative care side, because we do get tested for that on our board examinations. So with the actual setup of the team, and I'll have like a full video as well, specifically talking about the big things that I learned, but I just felt like it was very emotionally taxing. I had a lot of cases with kids in the ICU, specifically the pediatric ICU and the neonatal ICU. And I don't know, it was just very sad, seeing a lot of those kids that are born primarily premature or with some congenital abnormalities. And some of them are getting intubated, some of them are getting trachs. And it's just like, wow, these kids are going through so many big procedures at such a young age of life. And it should be just a huge happy moment for these family members that are coming in, having babies and supposed to go home, but then they have their babies stay in the hospital for months on end. So that was pretty emotionally taxing, and having those family meetings were pretty deep and pretty heavy, especially for patients that we have to, unfortunately transition to comfort care. But I did learn some cool things specifically about how it's different with pediatric palliative care as opposed to adult palliative care, specifically with the hospice side of things. With hospice and adult palliative care, it's usually you're done with treatment, you're not pursuing any more treatment to try to fix or reverse a condition that you have. But with pediatric hospice, we have something known as concurrent hospice care, which you can still kind of do some things for the actual conditions that you have, but you're also in that realm where if it doesn't work out, you can go just like the full hospice route. And there's not, at least in this area that I work in, there's not specifically designated pediatric hospice prep companies. It's the adult hospice companies that, if they have the capabilities, can do pediatric cases as well. And I was kind of asking them to see how that works. And it's hard because a lot of the patients in just our county in general don't have like very designated or dedicated pediatric care, especially in like the very rural areas. So a lot of these families that want to keep on going on with care and continue on these aggressive therapies, if they're really, really out far in the boonies, it can get pretty tricky and kind of hazy for them. So I don't know, despite all that, it was a pretty good rotation, because I think it opened my eyes to a lot more things in healthcare that I wasn't really privy to or really aware of. And I definitely don't think I would have been someone that was strong enough to do pediatric palliative care, just because it's very heavy for me. At least with my adult patients, they've lived a good semblance of a life. And as opposed to like these pediatric cases, like some of them are just born, like they haven't even left the hospital, and that's all they know, just living in the hospital. So yeah, that was just something I thought was pretty interesting from these last 2 weeks. I did get some good experiences because the two attendings on this palliative team for the pediatric cases are both ICU trained for neonatology. And it was cool because I got to hear a lot of different diagnoses that I don't really see in the adult world, because a lot of these patients that have a lot of these congenital abnormalities, specifically one that I heard about was congenital diaphragmatic hernia, where the hernia is supposed to stay down here in the lower abdomen region, but with the congenital diaphragmatic hernia, it's not developed correctly. So the diaphragm actually goes up into where the lungs are supposed to be, which is kind of tricky, because if you have the diaphragm where the lungs are supposed to be, then you're not able to ventilate and oxygenate those regions properly. So a lot of times, a lot of these kids have to get intubated or get trached, and even possibly getting a surgery. So having to talk to these families about possibly doing surgery or not doing surgery in a kid, it was very hard, because there's so many more complications. It's so risky. They're a lot smaller of a human being as compared to my adult populations, but it's still a risk they have to take and they have to discuss about. So I was doing a lot of family meetings with those family members, trying to see what are the risks and benefits that they are willing to accept. And it's different with the adult population, because with them, they have things that are more so directed towards what they think their quality of life they would want for their own quality of life. But for the kids, they don't know what they would want for a quality of life, and it's the parents that are determining that. So it can be quite heavy for parents to determine whether or not we choose a procedure for their child that is life-saving or not, and we have to be very sensitive to that. So having those conversations were very, very hard, but it was definitely something I needed to see, because I needed to take away, or I'm going to take away, a lot of the methods that these ICU doctors in the pediatric and the neonatology realms are using to try to adopt it to our adult populations. I think that's the biggest takeaway I can take away for managing those patients, because the specific dosaging and symptom management for kids, I'm not going to be doing that for the future. I'm going to be more so with the adult populations. So it was more so the goals of care conversations and getting exposure to that world and the resources that they have that I thought was most beneficial. So I don't know. Let me know what you guys think. I don't know. Yeah, there was just definitely a very hard experience, but very eye-opening. So I'm happy that I did it. All right, y'all gotta see this. There's light out. That means the shift is over. Life sure is sweet, ain't it? All right, so that's officially the end of the shift. It is currently 6:27 a.m. I have about 30 minutes left on my shift. We usually stop admitting around 6 a.m., 5:45, 6 a.m. because we have to have enough time to not only admit the patient, but also finish up all the documentation and all the notes for all the other patients. So right now I'm in a good spot. There's no more patients that are being presented to me by the ED. And it seems like the ED is actually completely cleared. I think there was like a bunch of people that were coming in for like non-admission criteria, so anxiety attacks. Some person came in for alcohol intoxication, which if they're not in withdrawal, we don't have to admit them. And then the other ones were just little small things like sore throats or panic attacks. So those are like the main things that were going on in the ED tonight. So it wasn't too active tonight, which I was really, really nervous, like I mentioned at the beginning of this vlog, because on my last admission, I didn't really admit anybody at all. I just didn't admit anybody because there's nobody that needed to be admitted. So I was like, is this going to be another get it back in blood admission type of night? But it wasn't. So thankfully it was chill. I don't think I have another shift here until, I don't think I have a shift all of next month. And I think I'm just specifically going to have like 3 or 4 in July. Let me actually check right now, actually. Yeah, so looking at my June month, I don't have any admission months because I actually just have a vacation that month. So I'm actually going to be off of these admitting shifts for quite a little bit of time. So that's going to be nice. By the time I do those 3 shifts in the July month, that's actually going to be my last month of fellowship. So I'm going to be able to stack up a little bit of money to be able to move into my new apartment that's going to be happening. And then after that, I'm going to go on vacation and prepare for my job that's going to be starting in September 1st for my full-time hospice and palliative care attending job. So looking really forward to that. This was a really, really good shift. I ate food. I actually rested a little bit. And for the rest of the time, I just did a little bit of my own personal work. So I'm going to be ending the video here for you guys. I hope you guys enjoyed this vlog for today. I wasn't too active, but I was able to kind of share with you guys some of the things that I was thinking about overnight tonight. And then we'll do another vlog. Probably the next vlog will probably be a hospice and palliative care vlog for the fellowship as opposed to one of these admitting shifts, just because I don't have another one till August or July, August time. So I hope you guys enjoyed the video. Like the video if you guys liked it, and subscribe if you guys are new. I'll see you guys later. Peace. Have a nice day. It's time for me to go to sleep.